Good morning. This session explores the major disturbances in blood flow, vascular integrity, and perfusion that underlie many acute or chronic clinical conditions. We will examine edema, hyperemia, hemorrhage, thrombosis, embolism, infarction, and shock. Understanding not only their mechanism, but also how they manifest clinically. So, by the end of this lecture, you will be able to connect this pathophysiologic process to a real patient presentation. So, this outline reflects the major hemodynamic disturbances. These are the main contents. So, this will show that affect tissue perfusion and organ function. We will move from fluid balance disorder to clotting abnormalities, then to embolic event, infarction, and finally shock. One of the most critical emergencies in medicine. So these are my learning objective. This objective emphasizes understanding mechanism, interpreting clinical consequence, and applying pathophysiology reasoning to real cases. So the core skills needed for analyzing hemodynamic disorders. So edema. The big question is how fluid normally stay balanced. Fluid movement across capillary is governed by two opposing forces. First is the hydrostatic pressure, which pushes the fluid out of the vessel. Then the oncotic or the colored osmotic pressure, generated mainly by plasma protein like albumin, which pulls fluid back into the vasculature. So, the lymphatic system provides a third stabilizing mechanism by returning excess interstitial fluid to the circulation. Edema develops when any of these forces becomes unbalanced. So, the increased hydrostatic pressure. When hydrostatic pressure rises, more fluid is pushed out of the capillaries that can be absorbed or reabsorbed. In your book, it highlights congestive heart failure as a classic example. Impaired cardiac output leads to venous congestion, especially in dependent areas like the legs. The result is pitting edema due to increased venous pressure. So this mechanism explains why edema improves when the underlying cardiac function is corrected. Next, decreased oncotic pressure or reduced oncotic pressure. Low plasma protein levels reduce the pull that normally draws fluid back into the vasculature. In your book, this emphasizes liver disease, reduced albumin synthesis, and nephrotic syndrome. Loss of albumin in urine as a key cause. With insufficient oncotic pressure, fluid accumulates in tissue and body cavities, producing generalized edema or ascites. Understanding this mechanism helps distinguish hepatic or renal causes from cardiac causes. Next, impaired lymphatic drainage. When lymphatic flow is blocked, interstitial fluid cannot be cleared, leading to lymphedema. So, in your book, the example here is what? Tumor obstruction, surgical removal of the lymph node, or radiation fibrosis. Unlike hydrostatic or oncotic edema, lymphedema is often non-pitting and localized to the affected region. Recognizing this pattern points clinician towards structural or malignant causes. So, when we connect mechanisms to diagnosis, the key teaching point here is what? The pattern of edema reflects the underlying pathophysiology. So, dependent edema think of heart failure. There's a hydrostatic. Generalized edema or ascites, think of liver disease or nephrotic syndrome. Think of oncotic. Localized, non-pitting edema, think of lymphatic obstruction. So this mechanistic framework helps students interpret edema not just as finding, but as a clue to the underlying disease process. There are some mechanism of edema like what? Sodium and water retention. Why? If you increase your sodium intake, what will happen? Water will follow. So water will be retained. There will be accumulation of water. You'll have edema. Transudate versus exudate. Transudative fluid and exudative fluid. What's the difference between the two? Transudate is protein poor, and then an exudate is a protein rich. Hyperemia and congestion. To distinguish hyperemia from congestion, hyperemia and congestion both involve increased blood volume in the tissue, but they arise fundamentally different mechanism. Hyperemia is an active process caused by arterial dilatation, usually in response to increased metabolic demand or inflammation. Tissues become warm and bright red because oxygenated blood is flowing. Congestion, on the other hand, in contrast, is a passive process resulting from impaired venous outflow. Blood becomes trapped on the venous side, producing a dusky, cyanotic appearance. Due to the accumulation of deoxygenated blood, this distinction helps students understand why hyperemia is typically physiologic or inflammatory, while congestion is almost always pathologic. Why congestion causes tissue injury? So when venous drainage is impaired, pressure builds up in the capillary bed. This leads to chronic hypoxia, cell injury, and eventually fibrosis. In your book, two organs where there is especially important. Number one is the lungs. Chronic left-sided heart failure causes pulmonary congestion, capillaries become engorged, alveolar septa thickens, and macrophage ingests leaked red cells, forming what they call a heart failure cell. Over time, the lungs becomes firm and fibrotic, impairing gas exchange. The other organ is the liver. It's a right-sided heart failure produces chronic passive congestion of the liver. The central veins and sinusoids become distended. Hepatocytes around the central vein undergo hypoxic necrosis. And the liver develops the classic nutmeg appearance. Losing standing congestion leads to fibrosis, radiating from central vein, a pattern distinct from other chronic liver diseases. So this example shows how congestion is not just a hemodynamic findings, but a driver of progressive organ damage. So linking mechanism to clinical cause, understanding whether the primary problem is increased inflow or what they call hyperemia or impaired outflow, what they call congestion. Helps clinician identify the underlying disease category. Cardiac failure. There's venous congestion from impaired pumping. Liver disease, reduced oncotic pressure, and secondary congestion. Renal disease, fluid retention, worsening venous pressure. Lymphatic obstruction, localized congestion, and edema. This lymphatic obstruction, an example is elephantiasis. So recognizing the mechanism behind the color, texture, and distribution of tissue changes allow us doctors and students even to interpret pathology specimen and clinical findings more accurately. Hemorrhage and hemostasis. So the spectrum of hemorrhage. Hemorrhage ranges from a tiny pinpoint bleeds to life-threatening blood loss. And the size and pattern reflect the underlying mechanism. Petechiae are minute hemorrhages caused by platelets abnormalities and capillary fragility. Purpura and ecchymosis represent progressively larger bleeds into the skin or mucosa. Then we go to hemothorax, hemoperitoneum, and massive external hemorrhage occur when large vessels are disrupted. This spectrum helps students link the clinical appearance of bleeding to the severity and location of vascular injury. Components of normal hemostasis. So hemostasis depends on the coordinated function of platelet, coagulation factors, and endothelial regulation. This is what platelets provide the initial plug through adhesion, activation, and aggregation. Coagulation factors stabilize this plug by generating fibrin through the coagulation cascade. And endothelial cells regulate the balance by producing both prothrombotic mediators like the von Willebrand factors and tissue factors, and the antithrombotic factors such as prostacyclin, nitric acid, and thrombomodulin. So, your book emphasized that hemostasis is tightly controlled process designed to stop bleeding without triggering unnecessary clotting. So, how defects lead to bleeding or thrombosis? Disruption in any part of the hemostatic system can shift the balance toward either hemorrhage, or thrombosis. Platelet defects, whether quantitative, thrombocytopenia, or qualitative, defective adhesion or aggregation, produce mucocutaneous bleeding, petechia, and prolonged bleeding time. Coagulation factor deficiency also, such as hemophilia, impair fibrin formation, and cause deep tissue or joint hemorrhage. Endothelial injury or dysfunction can tilt the system towards thrombosis by exposing procoagulant surface or reducing anticoagulant signals. Conversely, excessive anticoagulant activity or loss of endothelial integrity can promote bleeding. So understanding which component is affected helps the clinician interpret bleeding patterns and laboratory findings, and connecting the mechanism to clinical interpretation. So recognizing whether the primary defect lies in the platelet, clotting factor, or endothelial regulation allows doctors to interpret the type, location, and severity of bleeding. This mechanistic framework also explains why some disorder present with superficial petechia, while others cause deep hematomas or massive internal hemorrhage. So it reinforces the idea that hemostasis is a dynamic balance, and disturbance can manifest either bleeding or inappropriate clot formation. Thrombosis. So the core mechanism behind thrombosis. Thrombosis develops when normal hemostatic balance is disrupted. The classic framework comes from a Virchow triad, which identified three major contributions or contributors: endothelial injury, abnormal blood flow, and hypercoagulability. Endothelial injury is the most important factor because it exposes procoagulant surfaces and reduces natural anticoagulant signals. Abnormal flow, either stasis or turbulence, disrupt laminar movement of blood, bringing platelets into contact with endothelium and preventing the illusion of activated clotting factor. Hypercoagulability reflected inheritance or acquired tendency towards excessive clot formation such as factor V, Leiden, or malignancy. These three elements interact and mostly clinically significant thrombi arise from a combination rather than a single isolated defect. Morphologic clues distinguishing ante-mortem from post-mortem clots. So your book emphasizes that ante-mortem thrombi have a characteristic structural features. Because they form in flowing blood, the most important is the presence of lines of Zahn, alternating pale platelet fibrin layers and darker red cell-rich layers. This lamination indicates that the clot formed while blood was circulating, helping the pathologist distinguish true thrombi from post-mortem clots. Antemortem thrombi, on the other hand, also tend to be firm, attached to the vessel, and often propagate in direction of blood flow. In contrast, postmortem clots are gelatinous, not attached to the wall, and show a chicken fat upper layer and a darker dependent without true laminations. Recognizing this difference is essential for determining whether thrombosis contributed to the cause of death. So, possible outcomes of thrombus. Once a thrombus forms, several outcomes are possible, each with distinct clinical implication. First is propagation. The thrombus enlarges, accumulating more platelets and fibrin, increasing the risk of vascular occlusion or embolization. Next is embolization. Portion of the thrombus breaks off and travels to the distant site. Venous thrombi typically embolize to the lungs, while arterial thrombi may lodge in organs such as the brain, kidney, or spleen. Dissolution. Early thrombi may be removed by fibrinolysis, restoring normal blood flow. So these outcomes become less likely as the thrombus becomes more organized. Organization and recanalization. Over time, thrombi can be incorporated into the vessel wall through ingrowth of endothelial cells and fibroblasts. Recanalization may partially restore flow, but chronic obstruction can lead to tissue ischemia or post-thrombotic syndrome. So these outcomes illustrate why thrombosis is a dynamic process with consequences that range from clinically silent to life-threatening condition. So embolism, source and types of emboli. Emboli represent a intravascular material that travels through the bloodstream and lodges in the distant site, causing obstruction. So they can originate from several distinct sources. Thromboemboli are the most common and arise from fragment of blood clots. They detach and migrate. Fat emboli, typically following a long bone fracture or soft tissue trauma, where marrow fats enter the circulation. Air emboli occurs when gas bubbles enter the vasculature, such as during trauma, surgery, or decompression injury. Amniotic fluid emboli are rare but catastrophic event in obstetric caused by entry of fetal debris and amniotic components in two maternal veins, recognizing the type of embolus helps clinicians understand the underlying cause and anticipate complications. Pulmonary embolism and its clinical impact. So, pulmonary embolism is one of the most frequent and clinically significant form of embolic disease. Most originate from deep vein thrombosis in the legs and travel to the pulmonary arteries. Small emboli may be clinically silent, but larger ones can obstruct major pulmonary vessels, causing acute right-sided heart strain, severe hypoxia, or sudden death. Recurrent small emboli can lead to pulmonary hypertension and chronic right heart failure. So this spectrum from asymptomatic to fatal illustrates the pulmonary embolism is a major cause of morbidity and mortality in hospitalized and immobilized patients. Next is the systemic emboli or organ infarction. Systemic arterial emboli usually arise from the heart, especially in the setting of mural thrombi after myocardial infarction, atrial fibrillation, or valvular disease. So once in the arterial circulation, this emboli travel to the organs with high blood flow. The brain is the most common target, where embolic occlusion produces ischemic stroke. The kidney, spleen, and lower extremities are also frequent sites, often resulting in wedge-shaped infarct due to sudden arterial blockage. Because systemic emboli originate proximally and travel distally, the pattern of organ involvement reflects the branching anatomy of the arterial tree. Linking embolic type to clinical consequences, understanding the source and composition of an embolus helps predict its behavior. And clinical effects, so the thromboemboli obstruct vessels and cause infarction. Fat and air emboli trigger mechanical obstruction plus inflammatory responses. Amniotic fluid emboli provokes both vascular blockage and systemic reaction. So this mechanistic framework helps students interpret embolic disease not as a single entity, but as a group of related processes with distinct causes and outcomes. So infarction. What is an infarct? An infarct is an area of ischemic necrosis caused by occlusion of an arterial supply or venous drainage. So, an infarct is an area of ischemic necrosis caused by occlusion of either an arterial or a venous drainage, arterial supply or a venous drainage. So most infarct results in arterial thrombosis or embolism. There are two types of infarct, a white versus red, anemic versus hemorrhagic. Red infarct or hemorrhagic infarct, these are venous occlusion like testicular torsion, loose spongy tissue like the lungs, tissues with dual blood supply like the lung and small intestine. Previously congested tissue, reperfusion of arterial occlusion, supporting line here is red infarct occurs with venous occlusion in loose spongy tissues with dual circulation and when flow is re-established to a site of a previous arterial occlusion. On the other hand, white or anemic infarct, these are arterial occlusion. Solid organs with end arterial circulation, like the heart, spleen, and kidney. Dense tissue where blood cannot seep into necrotic areas. Supporting line here is what? White infarct occurs with arterial occlusion in solid organs with end arterial circulation, where tissue density limits each seepage of blood. So what are the factors influencing infarction? This determines whether an occlusion actually produces necrosis. Number one, collateral circulation, the most important determinant of infarction outcome. Organs with dual supply, the lung, liver, hand or forearm, are protected. And arterial organ, kidney, spleen, are highly vulnerable. Supporting line here is the availability of an alternative blood supply is the most important determinant of whether vessel occlusion will cause tissue damage. Number two, the rate of occlusion. Slowly developing occlusion allows time for collateral vessel to expand. Sudden occlusion, infarction, more likely happen. Supporting lines, slowly developing occlusion are less likely to cause infarction because they provide time for development of collateral pathway. Number three, tissue vulnerability to hypoxia. Neurons, irreversible injury in 3 to 4 minutes. Myocardium, 20 to 30 minutes. Fibroblasts survive for hours. What's the supporting line? Neurons undergo irreversible damage when deprived of their blood supply for only 3 to 4 minutes compared to a myocardial cells die after 20 to 30 minutes. Number 4, systemic oxygenation. Low blood oxygen content like anemia, shock, respiratory failure increases both likelihood and extent of infarction. What's the supporting line? Abnormally low blood oxygen content increases both the likelihood and extent of infarction. So morphology, there is a wedge-shaped infarct with apex at occluded vessel, coagulative necrosis in most tissue, liquefactive necrosis in the brain, acute inflammation at margins in 1 to 2 days, and then healing, there will be scar formation, except for the brain. So just remember, infarction is an ischemic necrosis due to vascular occlusion. Red versus white infarct depend on the tissue type, blood supply, and mechanism. Collateral circulation is the most important protective factor. Tissue sensitivity and systemic oxygenation strongly modify outcomes. Shock. What is shock? What shock fundamentally is? Shock is a state in which the circulatory system cannot deliver adequate oxygen and nutrients to tissue, regardless of the initiating cause, hypovolemic, cardiogenic, obstructive, or distributive, neurogenic, anaphylactic. The core problem is inadequate tissue perfusion. When perfusion drops, cells shift to anaerobic metabolism, accumulate lactate, lose membrane integrity, and eventually undergo irreversible injury. This progression explains why shock is a medical emergency across all clinical settings. So why all forms of shock converge on cellular hypoxia, even though the trigger differ, the downstream effects are similar. Reduced perfusion leads to what? Mitochondrial dysfunction and decreased ATP. Failure of ion pumps causing cellular swelling. Metabolic acidosis from lactate accumulation. Endothelial activation worsening capillary leakage. Progressive organ dysfunction, especially in kidney, lungs, and brain. This shared pathway explains why late-stage shock looks similarly clinically and regardless of the initiating mechanism. What makes septic shock distinct? Septic shock is not simply low blood pressure from infection. It is a profound dysregulation of the host response. In your book, this highlights several key mechanisms. A widespread inflammation triggered by microbial product and cytokines. Endothelial injury, leading to increased permeability, vasodilation, and microvascular thrombosis. Maldistribution of blood flow, so even normal or high cardiac output fails to perfuse tissue effectively. Metabolic derangement, including insulin resistance and mitochondrial dysfunction. Organ dysfunction, especially acute respiratory distress syndrome, or what they call ARDS, and acute kidney injury, or AKI. The combination of vasodilation, capillary leak, and microthrombi makes septic shock uniquely dangerous and difficult to reverse. Linking mechanism to clinical consequences. Understanding the mechanism will help you interpret clinical findings. Number one, the cold clammy skin. Low cardiac output states that what? Less blood coming to the extremities. Hypovolemic or cardiogenic. Warm flush skin, early septic shock due to vasodilation. Oliguria, renal hypoperfusion. Altered mental status, cerebral hypoxia, elevated lactate, marker of anaerobic metabolism and severity. This pattern reflects the underlying pathophysiology rather than isolated symptoms. So why organ failure develops? As shock progresses, microvascular injury and persistent hypoxia leads to ARDS from pulmonary endothelial damage, acute tubular necrosis in the kidney, ischemic necrosis in the liver and gut, coagulopathy from consumption of clotting factors and DIC. So this multi-organ failure marks the transition from reversible to irreversible shock. So this concludes our overview of hemodynamic disorder, thromboembolic disease, and shock. So any questions you want to ask? So this is my quote. It's showing the rapidly deterioration seen in shock, thromboembolic disease condition where early recognition and decisive action save lives. Sometimes you gotta run before you can walk. So these are my references and thank you.